We move to our شاعر والأديب, interventional cardiologist, Dr. Abdulrahman Alqahtani, and take us through a small sparkle. شوف ما شاء الله حتى عنوانها كلها شعر. Wildfire unexpected cardiac arrest during elective cath.
Okay, good afternoon, everyone. Thank you for organizing committee for inviting me, allowing me to have this chance to share with you this case. Thank you, Dr. Fawaz, for inviting us. So, Dr. Abdulrahman Alqahtani, some of you met before, some of you I'm new to. So, I'm the head of interventional cardiology at King Fahd Medical City in Saudi Arabia, Riyadh. So, Dr. Abdullah Shahab Abu Shahab is very fan of poetry, so this is dedicated for him. So the title is Small Sparkle Wildfire, and comes from the saying in Arabic, أبو الطيب المتنبي كل الحوادث مبدأها من النظر ومعظم النار من مستصغر الشر كم نظرة فعلت في قلب صاحبها فعل السهام بلا قوس ولا وتر. So this case did to me what no arrows or weapons have done to me before. So quickly going into the case. So I have this guy, 69 years old gentleman, dyslipidemia, hypertension, type 2 diabetes, and non-ischemic cardiomyopathy. He presented to our hospital now it's a few months with non-ST elevation MI. At that time, he had an echocardiogram, which revealed that he has an ejection fraction about 35% with regional motion abnormalities that I will show to you. This patient had a cath at that time, and he was accepted for CABG, but on the day he was admitted electively for his CABG, he refused, and then I was consulted to see him. So this is his diagnostic cath. So his right coronary artery is non-dominant. There is a significant disease in the mid-segment. His left main is short, but there is a left main equivalent lesions at the ostium of a dominant circ. There is also significant lesion in a large OM3 and a proximal LAD that heavily calcified diffuse disease. When you go to the cranial view, we could see that even the mid LAD has a significant disease, and you could appreciate that the first diagonal, even though it's medium size, is very long artery that's and supplies most of the lateral wall. You could appreciate here the degree of the disease at the ostium of the LCX and OM3. So this is his echo. You could appreciate that the anterolateral wall is slightly down, the apex is down, and you could appreciate that the whole anterior wall, even though it's not clear, is hypokinetic. The inferior wall is still moving well. There is mild MR as well. And there is no significant aortic disease, and you can see the anterior septal is still bouncing nicely, but the apex is not very great. So for the sake of time, I'll just ask for a show of hand. So if you were the operator for this patient, so this patient is coming now electively. It's not the time where he had his non-STEMI. It's already been a couple of weeks, and he was supposed to have bypass surgery, but he had cold feet on the day he presented to the hospital and decided that we are safer as interventionists. Well, we believe so, but not all the time. So anyway, would you consider this patient, given the lesion that I've seen before? I'm just gonna show you here. This is the LAD, the whole disease in the LAD, and this is his LCX. Would you consider him for a provisional left main LAD stent? I would like to see show of hand who would consider single stent approach. So no one, I'm assuming that everyone will consider two-stent approach in this patient, given that he has a dominant LCX. Who would consider fixing the OM3? Anyone? Okay, so it's a sizable branch. It's big, it goes all the way to the, almost the apex, and you could appreciate it here, it goes all the way, you could see how far it extends. So the plan was basically dedicated to stent technique. If I'm dealing with left main, I will consider DK crush in this situation. The size of both arteries is almost the same, even though the LCX looks even bigger than the LAD. It is just because of the degree of atherosclerosis in the LAD. Use of mechanical support. Anyone would consider mechanical support in this patient? So I see a lot of, almost 30-40% would have them. So I'm assuming you guys have them readily available. I would say that not every hospital have them readily available. And if you have them, you really need to be aware how to use them and how to assess them and troubleshoot them. So I do not personally pursue mechanical support unless there is a clear necessity for it. In this patient, he was hemodynamically stable. He was being a couple of weeks after that. And I don't use intra-aortic balloon pump in those cases. And Impella, there is a lot of issues with Impella right now. There is data that came out about 2 years ago about increase in mortality and the risk of lower limb injuries and hypercoagulability. So using Impella electively is at a question right now. So anyway, we decided to go ahead, PCI to the LAD, the LCX, 2 stent techniques as planned. And also, I was planning to do the OM. I was hesitating, but I decided to do it. So I took just better picture because the diagnostic was not giving me a clear insight of what's going on to that med LAD lesion. And you could appreciate that the lesion is very long, and you know this, you have a segment here and you have this proximal segment and this large D1. So I protected D1 because it's big, and I ballooned, and now I'm deploying the stent. I was not actually thinking to go after that mid segment until I have to. And after I've done this, this is what you see. So this long branch of D1 is now down. I actually tried with mini wire to try to cross. I still have this gelled wire, and eventually I had to go behind the stent with a 1.5 balloon and just try to open the ostium. Once I opened the ostium, I established flow, and then the flow is back, and then I managed to rewire it through the struts after I post-dilated that stent. Then, before putting a stent, I prepared the lesion. I actually used cutting balloon in this lesion. So I used 2.5 and then 3.0 NC, then a cutting balloon 3.0 at this lesion, and then I bought a 2.75 stent. You could see a balloon already in the LAD for crushing it after deploying it. So I deployed it, I crushed, and this is my first kiss. So I already recrossed, this is my first kiss. So now I've dealt with the circ, and this is what the picture looks like. So the circ looks fine, okay, fantastic. And it's already crossed. The OM3, at that time, I have not decided to touch. I was just dealing with the big boys and just want to deal with that later on. And you could appreciate that the lesion in the proximal LAD is getting even worse, and you could appreciate how bad it is. So I was planning to do IFAS at the beginning with the Volcano, but it didn't work. So I got once I got the machine, it was Boston at that time, and I did IFAS to the circ, and then I did IFAS to the LAD, and this is just showing you what matters, the LAD IFAS. So this is just to the stent. You can see still plaque and calcified arc around the distal part of the stent, and then you can see the stent. It's well opposed. There is a certain area that is not well expanded, but you could appreciate this is about post-tilt with 3.25 afterwards, and you could see there is still some area that is not well expanded, but so far so good. And then we will see the proximal LAD. Now we're getting into the proximal LAD soon, and you could appreciate how bad is the proximal LAD. So we have 2 areas that still need to be expanded. Look at the proximal LAD. Look at the calcium, and you'll see the calcium will get worse. And you see heavy burden of calcium, almost 360 degree of calcium. And then you get into the left main, a little bit of calcification around the circ, but there is already strut. So we kind of size the left main is about 4.0, 4.25. So we used a 3.0 a stent. But before that, look, I've already placed my wire. I said before I go and close the left main to the LAD to left main, let me try to open that. I was actually, it's a short discrete lesion. So I wired it. Then I took a 2.5 balloon. It will not go. I took a 2.0 balloon. It will not cross. I stopped. I pulled my wire. I was worried I'm subintimal because it didn't look that bad to me. And I crossed again. And again, 2.0 will not cross. 1.5, it will not cross. I actually went with the smallest CTO balloon that we have, 1.0. I will not cross. And even with hammering with the balloon, trying to give it some resistance support, it will not go. And I said at that time, you know, هذا الجهد. This is the last thing I'm going to do for it. I gave it the best chance, and I'm done. Like, you know, I'm excused in front of people, in front of everyone. I've done what I'm supposed to do. And then I decided now to finish my case, closed the LAD into the left main, and while I'm inflating this balloon, the patient is becoming bradycardic. I showed you this is the left main, you know, it's bradycardic. But he started to become nauseous. It's like we're getting a very bad vagal effect. And then the moment I'm taking this picture, patient is going into VF. And at that time I didn't realize, but look at the OM3. The OM3 went down. Just the moment we pulled that wire before I closed that stent, we lost the OM. And from there, it's not جلمود صخر حطه السيل من علي, but it's even worse. So I have this patient now where I can see there's some haze distal. You see the left main is fine. I just lost this tiny guy. And this tiny guy was a rebel. Like, he was really crazy. Like, the guy was an incessant VF. So I'm running my code now. It's like 10 minutes, and I'm not getting it. I'm shocking him. I've done things that I normally don't do. Like, I put like 4 pads on him. Like, instead of 2, I doubled everything. Like, I want him to get out of this VF, and I'm not able to basically break out of it. So incessant VF, I'm running code now for 10 minutes. I'm reaching 20 minutes. I'm actually very helpless. And I feel at that time, this is the worst thing. Like, the guy was like an elective case, came, who was supposed to go for surgery. He decided not to go for surgery. He trusts us more, and I'm the one who's given him one-way ticket. So I felt quite helpless at that situation, to be honest. And I was like running out of ideas. Like, I've given everything I can think of. I tried to give intracoronary stuff, you know, epi, etc. I just need to I actually put a pacemaker, and I tried to overdrive pace him, trying to get him out of the VF by going overdrive pacing, and that was not successful. So now I'm reaching 20 minutes, and I said, you know what? Screw it. We're not gonna do this. I activated the ECMO team. So each hospital is a bit different. So in our hospital, when I started, ECMO was under ICU. So it's run by ICU with the support of cardiac surgeon, because they were doing a lot of VV ECMO. By the time I came back, and we started to take away from them the VA ECMO, because this is more of a cath lab. So I activated the ECMO, we got the ECMO, I got the catheters, everything, and we started. So after that, we started, we managed to put ECMO, and the moment he was on ECMO, one shock, he's back. All what it took is to get the heart out of the equation, and then we get him controlled. So we kind of talked about this, and I think a couple of things is very important, is when you have a patient who's elective and you have a clear reversible cause, but you're in a situation where things are not working. And I think that's similar to the situation that Dr. Hamid presented today. Like, you know, things were okay, but then you're in a situation where things are going worse, and they were not working. And what's your algorithm? What's at your disposal? And you have to know your place. You have to know your colleagues. You have to know the surgeon that you work with. You have to know what's available to you. I'm going to finish soon. Just I want to show you what we've done. So after, you know, you could see this is Locus on board, and I'm doing CPR, and I'm trying to inject. I'm still having that. Once we got the patient on ECMO, and you could see now he's coming back, I just needed to wire that OM3. And the moment I wired it, it went through, the artery is open, and the patient started to stabilize. But now we have him on ECMO. The LV function dropped from 35 to about 10, and he went into severe MR. And the severe MR is because of the lateral wall went down because of this OM. So the moment we open it and start, the severe MR start, because there was a question, should we clip him right now, etc. Just, you know, hold your horses. Let's give him some time. And then they start to do that. And then you have to know what you're dealing with. If you are operating in a place with ECMO, and if you are going to use ECMO, you have to understand ECMO. You have to understand what does it mean, and what things you look for, and how you're gonna do it. And one of the things is called the LV venting, how to vent your LV. Because when you use ECMO, the heart starts to dilate and distend. There is increase after load, increase the wall tension, and then the heart starts to swell up like a balloon. So you need to know when that's happening, because you don't need that happening. So you have to have something called a mechanism for left ventricular venting. And there is multiple of them. We'll talk about them shortly. But that's what I plan to do later on. So after a patient stabilized, I actually finished my case. I did my kissing, everything. I did my POT, I did my imaging, and this is my final images, and the patient was in ECMO. Okay, you could see the TA probe, and you could see the results. You could see there is a possible dissection, something there. I left it for now. We have a flow. The heart is coming back slowly, crawling. And then what I've done after that is actually I started venting. When we did the echo, we saw that the patient has a BFO. So one way of venting is trying to increase shunt from the left to the right. So venting from that. So one way is to do left atrial septicectomy. That's one technique. The other technique is you put an impella into the LV, and this is called echopella. So basically you're venting the ventricle with the impella. Or you use a balloon pump. This the easiest one to do. That's simple, you can do. Or you use a manual technique. You put a big tail inside and you suction every time now and then, or put a negative pressure. Those will help. So the moment I saw that there is a BFO, I took it. I used a river balloon 4.0 by 4, and I just went ahead and opened that and created a good shunt, and we started to vent the left ventricle. So patient went to cardiovascular ICU. He stabilized, LV function improved back to 35. The patient is awake. The patient is actually following command. So alhamdulillah, we had him in a very good shape. And then I brought him 5 days after to decannulate him. And if you're going to decannulate, make sure that you are there. If the vascular surgeon is going to do it, make sure they're there, because they focus on something in the legs and forget everything. So this is the pictures of the LV, okay? And you could see that lesion is still there. Everything looks okay. I just took 2 pictures. You could still see that haziness. I wasn't planning to touch it for now. TIMI3 flow, walk away, small fire. It's okay. And you could see this is his final echo. He's still bouncing, it's snappy, and it's very good in situation, and there is no significant MR that we saw. And then I did decannulation. So I try always to do percutaneous. So what is that? Is a dry closure. So you go through a contralateral site for your arterial ECMO and inflate a balloon and try to close it with per close to per close. If it doesn't work, then you have to do open closure. And in this situation, it was not enough, because we did not deploy per close before. And finally, I just want to give some guidelines about this. So when do you need to consider ECMO? What is the time? And I think those are the things that we don't see quite often. And I think we should be looking into some kind of guidelines into helping us about to do that. So if you look at this hashed line, this is a regular mechanical compression of CBR. And this is on the ECBR, which is extracorporeal. So if you are doing CBR for 50 minutes, patient likely survival is 0. But with the extracorporeal, it can go up to 150. So the best time to consider is you should initiate your ECMO before 60 minutes. They looked into patients who died and who survived mechanical compression and found if you manage to do extracorporeal before 60 minutes, then the patient will survive. Okay, so initiate extracorporeal before 60 minutes. When should you initiate? You should consider initiating after 20 minutes. If you had a CPR going for 20 minutes and you had reversible cause, call for your ECMO. And it should be all up and running before 60 minutes. Those are the golden numbers. So the earlier you intervene, the better you get. And things that support favorable criteria: patient has a clear reversible cause, it's a witnessed high CBR, quality age is less than 70, and initial shockable rhythm. And you need to make sure that the end tidal CO2 is more than 10, so it means that you have an effective CBR, and you could see a sign of life under CBR, like patient is moving, groaning, etc. And if you see also if you start to have pulse. ECMO cardiac arrest, peripheral centrals. Peripheral is what we're going to be dealing with most of the time. And indication, and this is one of them, is like witness refractory ventricular fibrillation. It seems to be a theme. Like those patients that benefit the most are those who go into VF and continuous and does not respond to it. You have to have an exit strategy, etc. We're not going to go about that. And those all the venting techniques. And finally, I want to talk about this point: north-south syndrome. or Harlequin syndrome. And this is something that now a lot of cardiologists are aware of. So what happened basically, you are given an arterial oxygenated blood retrograde through the femoral. And you're given venous through the, basically you take venous from the SFC or the right atrium. And what comes out of the ventricle is non-oxygenated or deoxygenated blood. So the area where deoxygenated blood and oxygenated blood meets together is called the watershed area. And what is important, you have to make sure that you get enough arterial blood around the arch, oxygenated blood around the arch. If you're not getting that, the patient may get deoxygenated blood into the cerebrum, into the upper circulation. And that makes them look dusky. And hence the name Harlequin. And Harlequin is from the Italian mythology, is a character that is basically a demon-like character with a black face that chases certain spirits. So a person who has Harlequin syndrome will have a dark face, dark upper limbs, and red lower limbs. And that's because less oxygenated blood up there, better oxygenated blood. And what do you do to solve this? This is just a simple algorithm I wrote. It's basically you improve the oxygenation through the lungs. And that by improving ventilation and treating the lung pathology. Like those patients tend to have pulmonary edema, so make sure you're trying to treat that. And if that's not working, then you need to do better left ventricle ventilations, and by any means we've talked about. And eventually, if that didn't work, what you can do, take an arterial supply Y connector, take one from the blood and put it in the venous system, so you can get blood into the right atrium that is oxygenated. Those are some techniques that will help you to overcome this north-south, which is basically known as Harlequin. Thank you so much. And
thank you very much, Dr. Abdulrahman. Comments from the panelists, please.
Very good. I think this is a very nice case, honestly. It demonstrates a lot of techniques and a lot of how to get out of troubles. But I think the problem when you figured out that this OM is at the big artery and needs to be tackled, and your patient refusing the surgery and taking refuge with you, I thought he would need complete revascularization or as close as the surgery would have given him. At that particular point in time, I think if you had addressed the OM first before stenting the osteal circ, it would have been a nice, different story completely.
It would be, and it would not be presented. It would be. Yeah.
Congratulations, great case, excellent save. I agree with you. I will not put impella or mechanical circulatory support for every low ejection fraction patient or every complex PCI, but at least I will keep it ready beside as a bailout if needed. Then I will double check the viability again because the LV, it looks thinned out and dilated. But I will go again with PCI left main circ. Then I will do POT, then I will go to the LAD as a final strategy with focal stenting just to the proximal edge because it's diffusely disease the whole way. Whatever you do, you cannot cover all the atheroma. Thank you very much.
Really great case, Dr. Abdulrahman, and we can discuss about technique a lot and what we can do, but really I want to congratulate you about the timing you took. I will take this patient for the ECMO. This was a great decision. Thank you.
Hi, thank you. Very nicely done with the ECMO. Just have a question. Obviously, what I would have done, I mean, this is retrospectively, but the OM3, I would tackle the distal lesions first and then go proximally. That would make it easier for you. I don't know if you use different techniques to get your balloons down there, using anchoring techniques or guide extension catheters. I don't know whether you use this or not, instead of going with just smaller balloons.
Yes.
The other thing was, I mean, obviously maybe the vessel spasmed. I don't know if you gave vasodilators to dilate the spasm, relieve the spasm. That could have been the case here. That's my only comments.
So in terms of anchoring technique or technique, we didn't have a problem crossing the LCX, and we didn't have a problem delivering, and the guide was actually very supportive. The problem is just basically, I think we underestimated the lesion. We thought the lesion is easily crossable, which is not the case. Like that's is like a rota kind of a lesion that you need to use. I was hesitant to fix the OM3, to be honest, because I wanted to do the major ones in OM3, just leave it at the end. But then because I was worried about the LAD, to be honest, I was worried this patient is sick. And if I touch the LAD first and things start to go south, I'll just deal with the LAD and the proximal circ. But then when the LAD went fine and I managed to get that, I thought, you know what, let's give him the complete refasc, which we were hoping for. And we didn't actually achieve that. And instead, it was basically an artery that showed that to be very important artery at the end.
But did you give vasodilators?
The moment that the artery went down, patient arrested. So I didn't give any vasodilator. We were just resuscitating him afterwards.
Great case. بس هاي برا الكيس خالص يعني ما له دخل بالهاي اوكي. يمكن بعد تضحك. استخدمت two compression device صح قلت؟
We used no. Once it's about I used 2 bats to try to shock him, like so we have the regular one, and I put 2 on the side.
Okay.
I just
two defibrillator.
2 defibrillator.
Watch it. It's been some reported cases إن مثلا تحطهم متعامدين. You do يعني shock both together يعني يكون واحد operator وياك.
Yeah.
But does the job, but if it was an ischemic in nature, you might not get a good response with you.
Yeah, we didn't. We tried, we didn't. Like,
يعني if it كان مثلا VTAC, or you do
Yes.
whatever other like physiological something in the heart, you do اللي احنا نقول عنه متعامد يعني two
Yes.
pads, 2 pads,
Yes.
and then like 2 defibrillator, it might work, but with the ischemic, it might not be.
Yes.
يعني هاي الرefractory VFib احنا نسميه
Yes.
protocol.
One of the things that I think I don't see enough of ECMO done. I'm not a proponent of ECMO, but I think if we are doing more complex cases, we are going to deal with more complications that require this kind of support. And recommendation that you need to do at least more than 6. You actually should be more than 30 a year in terms of ECMO to be a center of excellence in this. And I think we just do 1 here, 1 there, and we don't build that experience. So I think currently in our cath lab, this is our default. We don't use yes. Yes.
Okay.
If you have a situation where irreversible cause and you cannot get the patient back with the 20 minutes of CPR, it is our we activate ECMO right away.
And I'm just saying for other people مثلا might see it في emergency refractory VFib, what they're gonna do في الطريقة المتعاملة حق الهاي, لكن if it was an ischemic in nature might not really work. It's just in your case. Yeah.
May I have a comment here? Just one, especially in cases with STEMI cases. I think we are underutilizing ECMO in cardiogenic shock in STEMI cases, because the earlier you put these patients on ECMO, the better the results you have. So really, we need to think about this.
I think 2 things why this not being utilized. First, it's complex procedure. Like it requires ICU care, it requires people who's very familiar with the hemodynamics, and not everyone trained on them at that time. Like the cardiac surgeons are more familiar with them, but they're not necessarily who's going to be following them. So I think if you're going to invest in ECMO, you need to understand and learn it, and be the one who's going to monitor, because we are moving to our ECMO patient in CCU, and in order to do that, you need to be really aware of the troubleshootings and things like that.
يعطيك العافية. Thank you very much.